Thank you very much, Corey, and thank you for inviting me, and thank you, organizers. But I really don't know how much power I have, but I'll take it if you say so. So I am going to talk what we are doing currently and what is coming up in pipeline. So if anyone has questions, you can interrupt me now or later. Later, okay. Okay. So as we all know, the lung cancer that we are talking about today is not what it looked like 2004, and 215 is what these small pies look like, but there this is outdated, so we have many more subsets now. So this led to about 2012, we had an NCI FDA meeting when everyone from the academia and government, we had a workshop, and the question at that point was, this was the time when TCGA data had come up, and people were thinking about where do we go in these molecularly defined subsets of cancers, and we had it about thoracic oncology. And out of after that meeting, a number of initiatives that were led by NCI came to fusion. So I'll talk to you a little bit about what the initiatives are and where we are. So one of the initiatives that we have is Exceptional Responder. That is ongoing. I'm sure that you all have heard of MATCH. That is ongoing. We have for lung particularly, so the first two are for any kind of cancer. So for specifically for lung cancer, at the moment we have Adjuvant Alchemist trial, which is for patients who have had lung resection, and then Lung Map. I'm sure you all have heard of that as well, which is a master protocol for squamous cell after they have failed one therapy or beyond. So what is NCI exceptional responders? It is that we know a patient from phenotype and then we test their genotype. It's a pilot study. We're trying to collect data about 100 patients. And basically, we all know that in our clinical practice or even in any kind of studies that most of the patients will eventually come to, there will be a median survival or median PFS, but there are few patients who will do exceptionally well. So this is not only clinical trial patients, anyone from your practice, if you think your patient has done well, more than what you expect from their median survival, can be enrolled in this trial. And so then what we plan to do is we are collecting their tissue and then test their molecular mutations or changes that have led to this exceptional responder. So that's really what this project is about, to understand why they responded. So this is how we do. A physician, actually, it was funny because last week a patient said, oh, I am an exceptional responder. So we respectfully said, okay, please ask your physician to put in your information. So anyone can go into CTSU where you put the information about people who you think are exceptional responders. Then we have an internal NCI review. So for each specialty, we have a panel or we have reviewers. So reviewers are, for example, I reviewed the lung cancer cases, and with me will be second person who will either agree or disagree. And then once a week we meet, we discuss these cases. Again, our argument is based on literature, what the median progression or median survival or median response or best response rates for these patients are. So we have an arbitrary definition of who exceptional responders are. For example, if they are not supposed to, their response rate is supposed to be less than 10%, but these patients has responded and have a PFS of more than 3 times what median is. So we are seeing very interesting patients. We will see again, we are collecting the tissue and we'll see what their genomic makeup shows. Last week I saw a patient who had extensive stage small cell and had lived more than 6 years. So there are few patients that I think and patient had not received anything more than what we give, cisplatin and etoposide. So why did this patient, despite having cisplatin and etoposide that we give to everyone, is living 6 years with a CR? So this is what we are looking at. So that's about exceptional responders. So what is NCI match? Again, so NCI match is a phase 2 precision medicine trial where the thought was that it may not matter what kind of cancer patient has, what kind of histology they have, but that if their tumor is taken and then you do collect their genetic information, and then based on that molecular, if we have a molecular target for which we have a drug, if we treat them, can this be helpful or effectively treat these patients? So this is a schema. A patient has had standard of care therapy. Now they have progressed. And then they will have a biopsy. And after the biopsy, if we have an arm for which they have a target, they will get on that arm. And if they progress, they are off the study. And once they are on that drug, then when they progress again, they will be re-biopsied, and they have another chance of going on another arm. And so this was a trial which again was, the idea was that we will target at least 25% of rare cancers. So a lot of people were saying, well, there are no trials for rare cancers. So this was one of the thoughts that we'll catch number of rare cancers in this clinical trial, and the goal was thought was about 25%. So we'll catch more than 25%. That will not be lung cancer, will not be colon, will not be prostate. And the primary endpoint were dual. One was the response rate, and the second was 6 months PFS. Small number of patients, only 31 in each arm. So it opened in August 2015. And it had 10 arms open at that time, and the goal was to screen 3,000 patients. And it was a planned pause at 3 months. We were going to see how the trial is doing and what are the things that we can do better or improve. And we stopped the trial in November 2015 for a planned interim analysis. So what did we find on that? Our goal was that we were going to hopefully be able to enroll about 50 patients per month. We actually surpassed that. We enrolled, instead of 500, we had enrolled 795 patients before we realized that this is the time that we had to stop. And because there was so much enthusiasm about this trial that a lot of patients got enrolled. So, and the other a good thing was that we were able to test 87% of cases, their samples were tested. And the main reason why some of the patients were not able to go on the trial was, again, not a surprise, was the quality of samples, why that was not good enough. So 9% of the patients out of those 700 plus patients were found to have gene mutations for which we had one of the 10 arms available, a bit less than what we had expected. Based on TCGA, we expected more patients to have these mutations, but that was not the case. And so the rate was found to be lower, and that out of those patients, 5% or 33 were able to enroll in one of the arms. So which means a number of patients did not enroll despite being able or despite being eligible for those arms. So what were the reasons why half of the patients were not able to enroll? So these are the numbers that the patients registered were 793. Cases sampled were good. It was 739. And 87 were able to complete their tumor assessment. And 9% we found mutation. And out of that, 5% only were able to be eligible for the clinical trial. But out of the 5%, only half, or 2.5%, were actually able to go on the trials. So again, this was a planned analysis, and that's where we learned what can we do to improve the trial. So what was good thing to know is that we were expecting that we will have at least 25% of the rare cancers. We were very happy to note that we actually had 65% of patients who had rare cancers. So which is what one of our goals was, that we should be able to enroll patients who have rare cancers for whom we have no clinical trials separately. And so we also noted that some of the patients who had a tumor biopsy, but if they also had cytology, it actually improved our value. So we were able to use those samples, and we were able to use them well. So we added cytology the next time. So we made changes to the trial. We actually now, from 3,000 screening, have increased it to 5,000. And we have opened the trial back, and instead of 10 arms, we now have 25 available arms for the treatment for this trial. And we expect that we will have at least a rate of 24 arms with 23%. We have increased the laboratory capacity. So one of the things that PIs investigators had brought to our attention, which that it took a bit longer. It took 3 to 4 weeks for us to get the biopsies back. And some of the patients had poor PFS and then ended up not going on the trial. So we have added clinical more labs that have been certified to do the trial. So again, the statistical analysis has been changed. We are making sure that we communicate with the physicians that if patient's performance status is good, it should not be 3 or close to 4, and then we are trying to get them on the trial. By the time they go on trial, they are not eligible. We are requesting that we have cytology on all patients, and that we will be able to use. Okay, that's about a match. So focusing on lung cancer, so we have 2 trials. One is the Alchemist trial, and both the trials have we had to make major changes or major amendments. And those amendments are based on the availability of immunotherapy that became not only available, it also not only clinical trials, but it also was approved by FDA. The idea was that we knew that at the time these Alchemist was planned, that we had drugs like crizotinib and erlotinib that showed good not only response but PFS and help patients in metastatic setting. So idea was, can we move these drugs to adjuvant setting? So this is what was decided, that we will have this as an umbrella trial, or some people call this master trial. So it's really a group of 3 trials. So the first one was the screening trial, where eligible patients, so these patients are resected, stage 1B to 3A, have to have negative margins. They can be screened pre-op or post-op, and once they have had surgery, they can have standard of care, whatever the physician decides, which could be chemotherapy mostly, but sometimes patients also get radiation if they have some nodal involvement. And after that, if they are ALK positive, they will go on crizotinib versus placebo, and for EGFR, they would go to erlotinib versus placebo. So this is how the trials were, how we started Alchemist, and so the second trial was for erlotinib by itself and crizotinib again with a placebo-controlled trial. So the objective was, can addition of these targeted therapies after standard of care, after surgery, add to the survival? So overall survival is the endpoint of these trials. Again, the patients who were not ALK or EGFR positive, we still collected their tissue. It is in a repository at NCI, and it is for further future testing. We also are collecting data on their epidemiology. So this will be a huge data set. We are, in order for us to get these patients for ALK and EGFR, we needed about 6,000 to 8,000 patients to be screened. So we'll have information on all of those patients. So this is the trial design, again, pre-op or post-op. Since, as you know, that ALK and EGFR is in a squamous cell non-squamous cell, so they were all non-squamous cell patients, and then everywhere, all the patients' tissues were collected. So what was the major amendment? One of the major amendment we had to do was to increase eligibility window, but the major other one was we had to add immunotherapy, because when nivolumab got approved, and this is what gives us a little bit of or a lot of flexibility about these master protocols, that if something doesn't work, we can stop the trial early, and if we have new information, we can add the arm. So we added an arm of immunotherapy to this trial. What also we had to do, as you know, that immunotherapies have been found to be helpful in not only non-squamous but also squamous cells. So we had to add about 600 patients of squamous cell histology to this trial. And this is what the trial looks like now. Again, pre-op or post-op, they will have ALK or EGFR testing done. If they are negative, then they will have PD-L1 testing done. Now, whether they are PD-L1 positive or negative is not defining their treatment. They will both subsets are going to be on the eligible for the trial, but this will be, the endpoint will be, it will be stratified by the PD-L1 expression. This is how it looks like at the moment. We have about 1,066 sites that are open. We have already enrolled 1,356 patients to the screening trial, and a smaller number as expected to the other arms. Now, immunotherapy arm has just started, so we're doing well with that immunotherapy arm. There is some concern because of the number of trials that are ongoing at this time in this space, including immunotherapy trials. So there is some discussion going on. We may make some more amendments to the trial to get this accrued in a timely fashion. So please keep tuned. So the last trial I'm going to talk about is the lung map. So lung map trial, again, master protocol got modified as things moved on. It was supposed to be a phase 2 and phase 3 randomized trial, and it was in patients who were squamous cell and had failed at least one therapy. And this is what it looked like when we started it. Each arm was separated by their genetic alteration, for which we had a drug, and it was randomized to a chemotherapy, which was taxotere at that time. And we also had an immunotherapy arm at that time. The first thing that happened was relutamab had a trial came up that it was not helpful in lung cancer and GI, so we had to stop that trial, and that immunotherapy arm got approved. So when the immunotherapy got approved, it was quickly amended, because now these were the patients who were eligible for immunotherapy, and we did not think that taxotere was a good or was ethically a good comparator for this. So we have made it as a single arm, and so these patients now have a smaller subset. It is still phase 2, phase 3. But phase 2 is going to be smaller numbers, and if it is positive, then it will go to phase 3. And we also had to stop arm C, which was a CDK4/6, because it did not, it was negative for its futility analysis. So there are more arms coming up into this trial, which is a PARP inhibitor. Impending opening of this is going to be very soon. Combination of immunotherapies, PD-L1 and CTLA-4 is coming. And so we are looking into more combinations. We will be looking at immunotherapy combinations and other targeted therapies for lung map. And so it will continue to open and close, and more discussions about what other histologies if we can add. So to keep with my time, so what are the new proposals under CTEP considerations at this time? We have NCI ELK, which is, we kind of thought about this trial a while ago. We were thinking about doing this as a registration trial, comparing each ELK drug, but there was less enthusiasm about this in the community. But now we have modified this. It will be based on the resistant mutations. So we're working at this hopefully in near future. There is some proposals that are coming for small cell master protocols. Again, nothing has been finalized yet. Mesothelioma, we have a clinical trials planning meeting for mesothelioma in sometime in March. So we are hoping that we'll be able to get one of the trials open for that. That will be a large trial. And we do have immunotherapy maintenance trials that are under considerations at this time. So in summary, master protocols provide a consistency of drug development regardless of what the target is. The idea was that we can pool patients together and we can have safely and effectively get drugs into the use for patients early by doing this. But on the other hand, a number of people here in the audience, including Corey, knows how hard it is to get these things together. It is very time and resource intense, and we are all on calls more than 3 or 4 times a week to coordinate these trials. And with that, I thank you.